All right, I'm Amber Price. I'm one of the fellows here this year at San Diego Spine, and today we're going to be talking about intraoperative neurophysiological monitoring and some of the advancements that we've made in the last couple of years. So just a brief little blurb about from a historical perspective, intraoperative neuromonitoring really dates back to the 1970s, where they first used spinal cord evoked potentials, actually in animal studies. And at that time, they had developed SSEP monitoring. Its actual first usage in spine surgery was described in 1972. And then we had the development of MEPs in the 1980s. The two weren't really used together up until the 1990s, and we'll kind of discuss the evolution a little bit of that. And then triggered EMG really developed kind of in 1992. And so those have been kind of from an evolutionary perspective, how it's kind of come about. A real brief discussion about some of the basics. So baselines are recording of pathways prior to surgical intervention or change in positioning. I think a classic example is getting baselines in your myelopathic patient before positioning on the table, just to make sure that there aren't any changes after a positioning. Waveforms. So when we talk about the warning criteria, it's important to understand what amplitude and latency are. So amplitude is determined in units of microvolts and is a measure from the baseline to the peak or the peak to the trough. Latency, I kind of think about it in terms of physics as like a velocity. So it's milliseconds per time interval in units. And it's the time it takes the stimulus to occur for it to then reach the potential. Somatosensory evoked potentials are what we'll first discuss. So these are monitoring primarily of the dorsal column pathways that are on the right-hand side there in blue. And they do not provide a direct measure of the motor function, but rather primarily the vibratory and perceptive senses that are found in the dorsal white columns. If you look at it intraoperatively, the typical stimulation points include the posterior tibial nerve, the peroneal nerve, the ulnar nerve, and the median nerve. From a reading perspective, amplitude is more important than latency. And so spinal cord changes or injuries without amplitude changes are unlikely. So when we talk about these amplitude changes of 50% or higher are considered significant. And so basically you have the stimulation, it passes through the peripheral nerve up through the dorsal root ganglion, the dorsal columns, and is then measured through the somatosensory cortex. You can't really talk about SSEPs without talking about blood supply and how they might affect the presentation of the patient. So the dorsal columns primarily receive their blood supply through the posterior spinal arteries, where the anterior 2/3 of the spinal cord actually is supplied by the anterior spinal arteries. And so an ischemic damage to the anterior spinal cord can go undetected. And these are actually two case reports from the early literature of using SSEPs in monitoring. On the left, this was in 1986. They described 6 patients who actually developed postoperative neurodeficits despite unchanged somatosensory evoked potentials during surgical intervention. And on the right is an example of a patient that had this happen to her. So she was actually a patient who had been diagnosed with an aortic dissection and developed anterior spinal artery syndrome. Intraoperatively, they used SSEPs to monitor her spinal cord, and it demonstrated normal morphology and latency. However, after she subsequently passed away, an autopsy revealed that she had developed a severe infarction of the anterior portion of her thoracolumbar spinal cord, and ultimately preservation of her posterior columns. And that's actually a section from the paper of her spinal cord. And you can see that there's infarct of the anterior columns with macrophage infiltration, and then relative preservation of the posterior columns. And this is actually a section of her intraoperative neuromonitoring which demonstrated normal SSEPs, including both morphology and latency. So it's something to keep in mind when you're using those. And this is just an example of kind of the differential of the two arterial distributions of the spinal cord. When we're talking about generators of SEPs, the neuromonitoring team will often talk about the P37 or the N20. So the P37 is the cortical response for the lower extremity, and so it's the primary somatosensory cortex for the leg. The N20 is actually the cortical response for the upper extremity and responds to the primary somatosensory cortex for the hand. And so this is kind of what their screens will look like, and you can see the N20 and the P37 being represented there. So when we're talking about changes in SSEPs, we like to talk about what is considered significant, or what is what meets the warning criteria for letting us know that there have been a change. For SSEPs, amplitude, it's the 50 and 10 rule, so amplitude less than 50% or a latency greater than 10%. A highly significant change is considered if the patient has lost complete loss of amplitude. There's also the popliteal fossa potential, and this is a way you can determine whether or not the patient has maybe perhaps had a stimulating needle dislodged, or if there's subsequent leg compression that's causing some lower leg ischemia. So this measurement basically ensures that adequate stimulus has been applied. If the popliteal fossa potential is absent in addition to the P37 change, then it's not typically a result of a lesion in the spinal cord. It's more likely due to technical changes most often, and so it can be from the stimulating needles being dislodged. You can ask the neuro team about this if you're having difficulty picking up that P37. Temperature also highly affects the SSEPs, so core body temperature changes that result in more than 1 degree of cooling can slow the conduction and affect your latency readings. So this is kind of one of the first bigger studies that looked at using SSEPs to monitor scoliotic surgery. It was a large multi-center survey, and they basically compared retrospectively neurological deficits that were compared to the SSEP monitoring. One kind of conclusion they came to was that when they used an experienced neuromonitoring team, they had fewer than 1/2 as many neurological deficits per 100 cases compared to teams with little monitoring experience. And so I think that speaks to the fact that, we have experienced neuromonitors, neuromonitoring teams in the OR with us, as the accuracy is much improved. They found basically a false negative rate of approximately 0.063% of patients, and so they highly advocated for using SSEPs in surgery. And we'll talk a little bit more about sensitivity.
Hey, Amber, did they say anything about like what experience actually meant? Like, did they quantify that?
So they talked about having greater than 5 years of experience.
Greater than 5 years, okay, cool.
For motor evoked potentials, so MEPs, we'll kind of dive into that, and then we'll talk more about the sensitivity and specificity a little bit later of each type. So motor evoked potentials can actually be monitored in different ways. There's 3 different main types of MEP monitoring. Transcranial magnetic stimulation is not used intraoperatively because it's number one, very bulky. The equipment that uses it can get overheated, and so it's just not really applicable for intraop. But you can have rostral spinal stimulation, and that was what was initially used, and then we subsequently developed transcranial electrical stimulation, which is much less invasive for the patient. So when we first started using MEPs, we actually used it with a single pulse technology, but because of the effects of general anesthesia, it was found to be really highly ineffective. And so We then had the introduction of basically a multipulse technology that allowed for a more reliable MEP recording. And so this basically allowed the MEPs to be monitored using very specific anesthesia protocols. And we'll mention that a little bit later. So this is an example of what MEP monitoring looks like intraoperatively. You can monitor the MEPs at different points, and those will correspond to different waves. So if you're actually monitoring within the spinal cord itself, within the corticospinal tract and the alpha motor neuron, that is the D wave. If it's a peripheral nerve, it's the H reflex. And then if you're monitoring at the level of the muscle, it's called a myogenic MEP. So what we're typically getting is the C maps or the recordings from the muscles, but you can. There is ability to record directly from the spinal cord. It's an epidural catheter that you can use, and this will produce the D or I waves that are more of a direct stimulation. So as far as significant changes for MEPs, so an increased threshold voltage of greater than 50 to 100, and I'll talk about kind of the, there's some argument regarding what appropriate voltage threshold is, but everyone is in agreement that a complete loss of amplitude is a highly significant change and should kind of set off warning bells. So this is a patient, an example of what the neuromonitors might see. So on the left is the left upper and lower extremity of the patient. On the right is the right upper and lower extremity of the patient. I labeled the muscles so it's a little easier to understand. So brachioradialis, interossei, thigh adductors, tibia, and adductor helicis. And so what you can see is that in red is baseline and green is the current neuromonitoring status. And so this patient has lost complete amplitude of the neurostimulation for the tib ant and adductor helicis on the left lower extremity. And this patient actually woke up, this was a case example, woke up with deficits in both. So that's kind of what you would see. So MEPs, there's discussion about what is the appropriate warning criterion for them. There are 3 different kind of techniques that are described. So there's the threshold technique. So basically you increase the amplitude of the response, and if it falls below 65% of the baseline, then that's considered a significant. What you'll see in the literature is a lot of people use 70%. And so it's just important to keep in mind that the target here often changes, and we'll show some studies later on looking at that. Amplitude techniques, so basically you increase the stimulus up to the maximum as long as the amplitude of the recorded response is maintained at an appropriate pre-selected level. And then the all or nothing technique, which is basically increase your stimulus to max, and if you see a significant decrease in the amplitude, then that's considered appropriate warning criteria. So it's important to talk to your neuromonitor person about what criteria they're actually using for their MEPs to make sure you guys are on the same page as far as what you would like to select. Triggered EMGs, so this is monitoring of the function of the nerve root, also known as stimulus-evoked EMG, but basically used as an agent during static phases of surgery. So we commonly use it during the testing of the pedicle screws, and is typically used to try to detect mechanical injury or cortical breaches. And the way it works is basically that cortical bone is not very conductive of electricity, but soft tissue has a low electrical resistivity or a high conductivity. And so when you touch the tip of the monopolar probe to the screw, the electrical output will give some sort of conductivity. In the case of a perforation of the pedicle, basically the flow of the electrical current takes the path of least resistance, so it will go through the breach to the root, and so the root will depolarize with a lower current. And so there's discussion regarding what that threshold might be, but this is actually from the Bridwell book, but this is 7 milliamps and an intact pedicle 10 to 12. This was a study that really first showed this being very useful for pedicle screw malposition. So they tested the pedicle screws at different milliamps, and what they found was the best sensitivity and specificity was actually found with a voltage of 8 milliamps. So highest specificity and sensitivity using a threshold of 8, and this was using 4,857 screws. So does that actually hold out with accurate pedicle screw placement? So this study looked at whether or not the triggered EMGs actually were able to identify incorrectly placed screws by removing the screw and testing for breaches. And they again found that the threshold of less than 8 milliamps is the most clinically useful. And then are they predictive of neurological deficits if the pedicle screw is placed incorrectly? This was a study that showed that basically if you have a pedicle screw that's stimulated using that 8 milliamp threshold, you're 10 times more likely to have a new postoperative deficit if not addressed. And so it does kind of translate out clinically as well. A little bit about anesthesia. So TIVA is preferred, and the reason is that the gases basically disrupt MEPs and SEP amplitude and latency, and propofol has less of an effect on that. So paralytics, they're actually better for SSEPs because they disrupt they prevent muscle function, and muscle function actually will disturb your SSEPs. So paralytics will actually show that your SSEPs improve, and your MEP and your EMGs will not be able to be obtained. So if you're getting really great SSEP readings, but for some reason you're not getting good MEP or EMG readings, you might talk to anesthesia about whether or not they still have paralytics on board. So a little bit about the sensitivity, specificity, and maybe associated risk factors. So this was a case looking specifically at SSCPs, and this was in non-myelopathic patients who were undergoing ACDFs for radiculopathy. It was a retrospective review. They looked at 1,039 non-myelopathic patients. They had a control group of 462 patients who did not have intraoperative SSEP monitoring, and 577 patients who did have the monitoring. And what they found was, interestingly enough, none of the patients in the control group had new postoperative neurodeficit. 6 in the neuromonitored group did have SSEP changes. 5 thought to be due to a transient hypotension, which subsequently resolved, which would be kind of consistent with why there was nothing in the control group, because these, had you not had SSEP monitoring, they resolved the hypotension regardless of whether or not SSCPs were there, and the patients didn't have any issues. However, there was one patient who woke up with a new neurological deficit. It was a partial central cord syndrome, and this demonstrated this patient had this despite having a normal intraoperative SSCP signal. So it is definitely not perfect. And some people argue that this is because it is basically a coherent average. So basically the patient, you're not getting a one moment in time look at the SSEP. It's actually an average of multiple minutes of SSCPs, and so they're delayed. So if your SSCPs fall, the injury could have occurred an average of 5 to 16 minutes prior to them actually showing any sort of a response. And so it's important to keep that in mind. MEPs, so then, they found that SSCPs weren't totally accurate and they could miss things. And so with the advent of MEPs, they kind of tried to use that and see how accurate is this? So this is a study where they looked at MEPs and their corresponding presence with new postoperative deficits. And their general sensitivity and specificity were found at 75 and 92%, with only a positive predictive value of 38%. This is one of the earlier studies. But what they did note was that the positive predictive value was higher when the recorded MEP change did not return to baseline. And that improved the specificity to 98% and the positive predictive value to 75%. So the takeaway from this study is if your MEP changes and it doesn't return to baseline, you are much more likely to see that your neurodeficit manifests itself postoperatively. The other thing that was found in this study was a subgroup analysis, and what they found was that patients with vascular disease had higher rates of postoperative deficits without neurological monitoring changes, and their sensitivity dropped to lower than 60%. If you then ruled out the people with vascular risk factors, so peripheral vascular disease, coronary artery disease, diabetes, then the sensitivity went up to 100%. So it's just something to keep in mind. If your patient has those risk factors, their neuromonitoring is going to be less accurate. So what they found was, well, if we put them together, does that improve the sensitivity and specificity? And so this is one of the first studies that looked at putting motor and somatosensory evoked potentials together and then analyzing postoperative deficits. And they found a significant improvement in the overall sensitivity and specificity. You can see those there, as well as the positive predictive value and negative predictive value. So what about in the world of deformity? So this was a study, a retrospective review, 176 patients. They monitored using MEPs and SSEPs, and those were the criteria that they used. So they used amplitude 75% and 50% for SEPs were considered to be positive changes. And then they looked at post-operative neurological deficits. So again, this just shows the specificity and sensitivity of the MEP and SCP monitoring when you looked at them separated versus together. So again, together is better. And then looked at what risk factors were present for neurological monitoring changes in these patients. And so patients were more likely to have neurodeficits with concurrent changes on their neuromonitoring if they had had an osteotomy, if they had a significant kyphosis prior to surgical intervention, and with Cobb angles of greater than 90 degrees. So those, if you have a neuromonitoring change in a patient that you have any one of those risk factors with, the likelihood is more that it is real. And then a little bit about more current literature. So this was a study that just got published in 2022. It was a prospective multi-center study between 2017 and 2020. They looked at patients who had spinal deformity, age greater than 20, and then they excluded neuromuscular syndromic scoliosis and ended up with about 311 patients. And they looked at when did the alarms occur, and then if they performed a rescue intervention, what was the actual rescue rate. And so what they found was that the majority of their alarms occurred either during the deformity correction or during the 3-column osteotomy. And so you can see 16 total of the number of alarms were real. So these, the other 22%, these were just things like hypotension, hemoglobin adjustments, things like that. And so obviously the rescue rate for that was 100%. But if you rule that out, if it's a real issue, it's usually going to occur during the deformity correction or during the 3-column osteotomy. And so this is kind of the discussion about what rescue intervention was used, and then how effective was it. And so they had about a 50% rescue rate for deformity corrections, and unfortunately only a 33% rescue rate with the 3-column osteotomy. And so here's kind of a closer look at those patients in particular, with the true positives being there, the first 11 patients. And interestingly enough, so this is using that selection criteria of 70% amplitude change. What they did have 3 false negatives. So 3 patients who woke up post-operatively with a neurodeficit but did not get alarmed by the neuromonitoring team. And this was the amplitude of baseline change when they looked back at the readings. And you can see that it was just because there were changes, but it was just because it didn't reach that amplitude change that they had preset. And so the discussion is that if you increase the amount of sensitivity, so say you decrease that, you want 60 or 50%, that might have garnered or grabbed patient 13. However, it's a trade-off between increasing your false positives. So they discuss like, well, stopping the surgery and changing things for things that are actually real false positives increase. So there hasn't been an actual selection of what is the appropriate cutoff base for the amplitude change because of that exactly, that you increase your false negative if you set it too high. So it's a trade-off. And then most importantly, thankfully, all their patients ended up recovering, and you can see that in their table there to the right. And then they again looked at risk factors, and the two risk factors for having a postoperative neurodeficit with a intraoperative neuromonitoring change was having a 3-column osteotomy, or if you had a pre-existing motor weakness, you were also more likely to have a nerve root injury postoperatively when you had neuromonitoring change. And I just think that's because the injuries you already have a decreased baseline to start with. So these were their key points. Again, the risk factors, so pre-existing weakness and 3-column osteotomies, and then further studies trying to figure out what an idealized warning criteria would be to decrease the rate of false negatives. This one looked at, it was a multi-center study. They looked at multiple different cases, 1,009 spinal deformity cases, and they used the 70% threshold. I think importantly from this study, the false negative rate was 9. And when you looked specifically at the deformity patients, what they found was what mattered was when the neuromonitoring change occurred. So if it occurred during your either rod rotation, your pedicle screw insertion, or your 3-column osteotomy, or any one of these different types of maneuvers, it was more likely to increase the true positive rate. And you can see kind of their rescue intervention rates. Theirs were thankfully higher with releasing like rod derotations, but again, the 3-column osteotomies rescue rate was low. So if it occurs during your cantilever or your rod rotation and you perform an intervention, you're more likely to rescue. But if it occurs during the 3-column osteotomy, there's a higher likelihood the patient's going to wake up with a postoperative deficit. And so basically, this is kind of their discussion regarding this increase in the true positive rate of the neuromonitoring alarm, and that the rescue interventions did lead to increased rates, approximately 60% if additional decompression and release of the derotation or the compression or distraction, depending on what was done, did show improvement for the patients. And this is, again, their discussion about the true positives and negatives. So real briefly about responding. This is kind of a summary table. So ruling out anesthesia-related factors, blood pressure, etc. This is kind of a way I kind of have broken it down in my head. So the first thing is neuromonitoring. Check the needles, check the lines, check the drill, the bovie. All those things can cause issues or positioning. And then the next thought is, anesthesia, adjusting gases, check the paralytics, especially if the SSEPs are doing well and the MEPs are not. Check the maps, check the temperature. You can put warm saline in the wound, oxygen and hemoglobin status, and then further discussion regarding what surgical intervention you just did and the timing of the neuromonitoring change. So remove the pedicle screw, release the rotation, etc. If there's no response, start steroids and maybe consider a wake-up test. And so this was actually published in 2018. I'm not going to spend too much time on it because I have the more updated version from 2022 coming up. But this is basically a checklist that one group basically instituted in their ORs, and they basically printed it out and set it up at a bunch of different areas. And so everybody was on board if what the anesthesiologist needed to do if, a change was encountered, what from the neurophysiologist standpoint they needed to do, and what the spine surgeon needed to do. And so they implemented that in their ORs to kind of keep everybody on board as a team. So in 2022, a bunch of our experts basically developed a consensus-based guideline practice. And I think this is more useful for the surgeon from the perspective of, well, number one, when did the neuromonitoring change occur, which we kind of talked about earlier. That is important. And then what was the maneuver that was occurring? Were you doing it during a posterior column osteotomy? Were you doing it during your 3-column osteotomy? Was it even prior to any sort of change, the pre-incision versus post-incision? I'm not going to go through each of these because it would take a whole lecture in itself, but it's something to go through and kind of try to familiarize yourself with about their recommendations. They also kind of give you a set of real-time data scenarios. So what if your intraoperative neuromonitoring improves but then degrades again? What are things that you can maybe do to try to address each of those things? And then the different types of patterns of intraoperative neuromonitoring loss. So if you just lose your MEPs, if you just lose your SSEPs, or if you lose them both together, and what might be occurring at that time. And that's what I've got. So hopefully that was a lot. So hopefully it wasn't too much. But
awesome talk, Amber. Thank you.
Awesome.
Thanks, Amber.
So one of the things that no one puts in these articles, by the way, Amber, and is a definite confounder, is technical error. So for instance, if you think about a 3-column osteotomy, nothing should be safer than a 3-column osteotomy, in my opinion, because you have absolute control over everything. You're able to shorten, you're able to lengthen, you're able to untwist, you're able to manipulate your mechanical environment theoretically to its greatest degree, unless somehow you disrupted the vascular supply or something like that. But apart from that, from having like a spinal cord stroke, like that's like the best scenario, right? So when you see like 3-column osteotomies resulting in like those kind of changes, like I wonder if there isn't some technical aspect to it that was a problem. Like you're impacting on the posterior wall and your turkey foot slips, or things like that may result in a change that is not necessarily related to having a 3-column osteotomy, but more maybe related to a slip of a hand or too much pressure on the spinal cord if you're retracting it one way or the other, that kind of thing. And that's where I wish there was a little bit more nuance in there. I mean, like correcting a scoliosis makes sense, right? Because you're manipulating the whole spinal column and you're probably doing a lot of lengthening around that area. So like it makes you say, okay, well, if I untwist it, well, then it should come back. Same kind of thing, right? Which usually does happen. But in a 3-column osteotomy, like to me, it's either technical error or it's like something really bad, like a vascular injury because you clip both nerve roots and now the radicular arteries are gone and there's you interrupted the blood supply. That would be horrible. So just to throw that out there, these studies are great because they definitely point us in the right direction. I love the protocols. I love for the most part because you have like your whole team engaged. And you don't have to worry about taking the whole burden on yourself because the whole team is going to be engaged in the process of getting those signals to come back. But so I think the result of having these protocols is phenomenal because it's literally what it should be in these situations because it's like flying an airplane and just being as safe as possible. Those are just a couple of comments thought I'd make.
Amber, that was a fantastic talk.
Thank you.
Any other thoughts, comments?
I'll just make one more that
The study you pointed out on ACDS, I think, is helpful. There's a whole lot of neuromonitoring done out there that's not useful, and it's a huge expense for our society. So be thoughtful about when you use it, that there's actually value in it. Don't use it for microdiscs and ACDS with radicular issues. Do it when it actually helps you make adjustments on the fly that are important for the patient care. So I thought that was a great study to highlight.
I've stopped using it for A-lifts unless there's some kind of like grade 2 slip where I could put the nerve under a lot of tension. But yeah, I agree. There's a lot of use that's not indicated and probably driven just by liability.
But is there any study to show that liability is improved upon if you have neuromonitoring? I've seen the opposite, actually.
Have you? No, I think it's a perception, Bob. I don't think there's any. I think it's just a perception.
Yeah, I've actually seen more liability where there's neurophysiology involved in a case they probably should have had in the first place.
You know, the thing is, though, Handy, is most of the time when you're doing an A-lift, you're probably going to be putting some screws in anyway, and you're going to use it for the back part. So it's unless you're just doing like a standalone A-lift or something.
Well, yeah, and that's a very good counter. I mean, for most of the A-lifts I'm doing, I'll use navigation, and I feel like I've only had one screw revision with the O-arm, so, but no, it's a valid point. It's a very valid point. And if I did have a screw go medial, so the navigation was off, then I think I would have some liability.
I'm not sure that there's any evidence to support that A-lifts you actually get helpful information. Most of the time, you get a delay in the neural function drop. It's not something you get real time. Anybody else have a different take on that? In other words,
Yeah.
It doesn't really help you intraoperatively.
Yeah, I think in the ALIF world, I'm extraordinarily dissatisfied. The number of patients, we should actually look up our series, guys, because we have enough of them where we've had to take patients back to reoperate on them to do foraminotomies and stuff because of postoperative deficits. Like, we really should look at that list because the incidence is high, and like for those of them that are monitored, I bet we have enough that are monitored and those that aren't to be able to see if there's any difference at all. Because all mine that I have like these horrible deficits, like 0 out of 5 foot drops, have normal monitoring. Like, I'm like, why am I even doing this? And
Greg,
I don't know
but
if
how
it's
many of those are
traction, it takes time.
neuropraxic though? You know, Greg, it's neuropraxic, and that's
That's
why.
what I'm saying.
Yeah.
So like the monitoring's not the savior in it. It's probably
Right.
traction, or there's we could identify, these are patients that have that like bony hook off of the inferior end plate of the
Right,
of the
F5, sure.
cephalad. Yeah, exactly. So I think those are the things that I think probably deserve to be identified, especially when it comes to like indirect decompression at 4.5 and 5.1, which I think is a totally different ballgame.
Right, and it's sort of analogous almost to like the C5 palsy, which,
yeah,
we looked at that with Hagigi a bunch of years ago, and if you had a certain threshold of spontaneous firing, you're probably more likely to have a C5 palsy. But yeah, like we don't see it with the A-lifts, and that's interesting. I wonder if there's a different paradigm we could do, like almost like TMAPs, you know what I mean? The trans abdominal motor evokes to see if there's any changes that way. I mean, we really should be investigated because I agree. And it's almost like, like when Lanky talked about this summer, it's sort of lengthening a fractional curve by so much. And then you get sort of that neuropraxic stretch on a nerve. We don't pick those up either. You discover them post-op and then you're really upset with yourself,
Yep. And there's nothing you could have done differently. And obviously you're upset with yourself, or your patient's really pissed.
Yeah, of course. Yeah, we should look at that because I think we all have enough of those patients in our clinics that we could pull something nice together.
Yeah.
I wonder though if in those patients, a lot of times the reason you're doing the A-lift is like, for instance, severe foraminal stenosis at 5.1, and the nerve root is already toast, and so you're monitoring a subtle difference, going from an injured nerve that's already probably spontaneously firing to just slightly more injured when that bony hook that you just raised up into the root is causing more injury. So it's just such a subtle, it might be just a subtle difference that it's not picking it up.
Yeah, it's the same. I agree. I'm not sure it's worth monitoring. I think you have to be thorough in your decompression. And the other one is the group that's been previously decompressed, where I think they may be tethered. Like if they've had a 4-5 or a 3-4 decompression or even a 5-1, and then you indirectly decompress them and you pull up, but they've had their L5 nerve roots already scarred to the lateral wall, like at 4-5 or whatnot. And then you think it'll just open up the foramen, but all you're doing is pulling on that tether, and it's causing a neuropraxia in a different way,
Greg, I had a same case 2 weeks ago, that exact same issue. A woman that had 2 microdiscectomies, and I did an ALIF, and she had worsened radiculopathy and had to go back in and basically lysis the scar. And that seemed to make a difference, which I was surprised. But that's definitely something to watch out
I think
for.
that happens. Yeah. So I think the risk factors are that, like, bony hook. I think it's revision decompression. What else? What else would be a good? Maybe too much height, so that you're actually translating the nerve more posterior, right? So you're actually pulling on that nerve, and that's
more listhesis reduction.
Yeah, that's a good point. Yeah, if you have to do more of a spondy reduction, and if you have all 3 of those,
triple whammy.
That may be that'd be interesting to look at.
That'd be a great study.
Yeah.